Hey, hi, folks. Good to see you all. My name is Bianca Frogner. I'm a professor at University of Washington in the Department of Family Medicine, and I direct the Center for Health Workforce Studies. But more critically for this, I'm part of the Award Network's Leadership Committee and the webinar chair. I'm really excited that we have Catherine Carroll Britt speaking with us today about exploring lifestyle factors of spirituality and religious activities for cognitive health in older adults with dementia. We'll have our moderator introduce her in more detail in just a bit, but I do want to go through some regular housekeeping. As always, we do record all of our webinars, and you can get access to them on our website, so you can see this and all past webinars online. We also would love to hear from you, as always, about future webinar ideas that you may have, and you can scan that QR code there on the side to let us know what you're interested in hearing about. There's a link when you get there to fill out a survey to do so. Also, next month, we have our annual speed sharing activity. This would be our third one that we'll be having. So this is an opportunity for about 6 to 7 of our award network members to present their work. It's a brief presentation of about 5 minutes or so, depending on how many people we get signed up. Uh, we have extended the timeline to sign up until Sunday, this Sunday, December 8th. So again, there's a separate QR code for that if you want to sign up and volunteer to present your work. You should have also received an email blast with this link there too. So please look for that and join us and let others know about this opportunity. And we're seeking volunteers for the award network. We have a number of leadership type of opportunities. We have a conference committee. So we have had, for example, a meeting at the Gerontological Society of America that just happened here in Seattle. Next year, I believe it's in Boston. And so we would love to have people who help us organize the activities that go along with these as adjuncts to these other larger conferences. We have the Pilot Award, which, by the way, the next round of Pilot Awards will open up sometime in January. And we would love to have people join our review committee for future Pilot Award reviews. And then, as always, we also have this webinar committee, and we have people rotating off, and we're always seeking new people to join our webinar committee to help us organize this, because really I couldn't do it without a fantastic committee of people. So again, there's a separate QR code for this and a different link here. And also, you should have probably seen an email or will see an email about volunteering opportunities. I just want to remind people about the Direct Care Workforce Data Compendium that's on our website. I've announced this probably the last couple webinars, so it's not necessarily new, but just want to remind people that there's some fantastic data there for folks who are looking for some more information about policies related to long-term care and the workforce related to caring for people with dementia. So very useful information there. So certainly want to encourage you all to check it out. And as I alluded to earlier, I have a great webinar committee that helps us organize this every month. And so I do want to thank them as always. And then also our leadership committee led by Joanne Spetz, who's the PI of the Award Network, for making all of this happen. And then also thanking our funder, NIA, for supporting this webinar. So with that, I'm going to turn it over to one of our fantastic Award Network webinar committee members, Jin Jun, who will go ahead and introduce our speaker for today. And take it away, Jin.
Sure. Hello, everyone. My name is Jin Jun. I am an assistant professor at the College of Nursing at The Ohio State University, and we are not going to talk about the game last week with Michigan. And I have a great privilege today to introduce my dear colleague, Dr. Kat Britt, on her very interesting and relevant topic. So Dr. Britt is an assistant professor in gerontological nursing at the University of Iowa College of Nursing. She recently completed a T32 postdoc research fellowship at the University of Pennsylvania School of Nursing. in their New Cortland Center for Transitions and Health. And she recently was a 2024 Butler Williams Scholar, which is run, or I guess it's a program by the NIA. And she also was a Psychology and Mental Health Jonas Scholar. Dr. Britt has been a nurse for over 20 years, practicing across the life course from pediatrics to gerontologic nursing. Her research focuses on identifying lifestyle factors such as spirituality and religious involvement to inform non-pharmacologic interventions for persons living with dementia, mild cognitive impairment, and their caregivers to slow disease progression and improve well-being in historically underrepresented populations. She also studies cognitive care planning, identifying ways to improve cognitive care for families facing Alzheimer's disease and related dementias. Dr. Britt is the vice chair-elect for Emerging Scholar and Professional Organization, and also the co-governor of the Religion, Spirituality, and Aging Interest Group for the GSA that Dr. Frogner just mentioned. Her work has been funded by the Population Aging Research Center at University of Pennsylvania, Jonas Philanthropy, and Duke National Survey of Religious Leaders. So with that, Dr. Britt, take it away.
Thank you so much, Jen. And let me just share my screen. Bear with me for a minute, please. All right, can you see that okay?
Looks good.
Okay, excellent. Again, thank you so much for having me, and you can call me Kat. Today I'm going to be talking about some lifestyle factors that I focus on in my research around spirituality and religious activities. And I'm mostly looking in cognitive health outcomes for persons with mild cognitive impairment and dementia. So today I'm really going to share some of my work, just a little background information before I share my research findings on a few different projects, and then I'll talk about some future directions. I always start with why I'm doing this work. So this is a picture of me and my father and mother, and I was the nursing or the medical representative in my family. And I had been in pediatrics for a long time as a nurse, but my father was diagnosed with Lewy body dementia in his late 60s. And my mother became his caregiver. And so I watched them kind of navigate this process of what to do about his symptoms and how to get medical care, and just realized how much is really needed to improve the lives of family members and loved ones facing dementia and caregivers. And so that really prompted me to go back to school. I switched to geriatrics. And this QR code here you can see is an op-ed that I published during my PhD um, years about my experience. But my father and my mother both eventually passed within 11 months of each other. So it was a very a hard time for me and my family, but I had to step up and make a lot of decisions that, being that medical representative. So I had a lot of perspective that kind of goes into my work. So just I'm going to talk a little bit first about dementia. I know a lot of you are familiar with it. For some of you that are not, this hopefully will just be a quick overview, but our population is aging and adults are living longer for the first time in history. Older adults will soon outnumber children for the first time, and we know that's because of the baby boomer generation. So as age is the number one risk factor for dementia, I'm using dementia as an umbrella term here that may include Alzheimer's disease and related dementias. So it's an increasingly prevalent terminal condition, as we know, that presently cannot be prevented or cured. It's declared a public health priority by the World Health Organization, and it's growing with our aging population. And at present, there are over 6 million living with Alzheimer's, which is the most common type of dementia. And you can see that here in this graph. The number of Americans with Alzheimer's is estimated to reach around 14 million by the year 2060. The World Health Organization's also deemed dementia one of the costliest conditions to society. In 2023, just kind of as an estimate, dementia cost the nation around $345 billion. And by 2050, those costs could nearly rise to 1 trillion. And you think about this being a progressive condition, right? It affects memory, thinking, decision making. It requires much care and assistance from others, mainly caregivers who are family members. Dementia caregivers are overburdened and report twice as many emotional, physical, and financial problems compared to caregivers of older adults without dementia. Cognitive disparities exist in this condition. So, African Americans and Hispanic Latino individuals are twice and 1.5 times as likely to develop dementia and cognitive impairment compared to whites. As the aging population continues to grow, so does the diversity of the population. So it's also projected by the year 2060 that 45% of the US population age 65 years and older will be part of a minority or non-white ethno-racial group, again prompting an increase in dementia. Here you see the dementia continuum over time, beginning with preclinical dementia, where a person may have no symptoms, but possible biological changes in the brain, advancing to mild cognitive impairment for some, with very mild symptoms that may not interfere with everyday activities, and then really moving through that mild, moderate, and severe symptoms of dementia where symptoms interfere with most everyday activities. And so as the dementia progresses, cognitive function declines. These three symptoms are seen in dementia progression, right? So cognitive decline, neuropsychiatric or behavioral symptoms, and sleep disturbances. So I just want to talk a little bit about those. As we know, cognition is the mental process of acquiring knowledge and understanding and really using that knowledge to inform decision making, learning and remembering things, right? Using that knowledge in everyday activities. And so individuals who struggle with memory and confusion often rely on others for their care and well-being. And that comes into play later when I'll talk about spiritual needs of persons with dementia. Neuropsychiatric symptoms are prevalent in mild cognitive impairment and more prevalent in dementia, around 58 to 75%. These are an established predictor of future cognitive decline. They often prompt earlier institutionalization and contain things such as agitation, depression, anxiety, apathy, delusion, things like that. And they can really have adverse, serious consequences for patients, but also caregivers trying to provide care for their loved ones. And then sleep, we know, is an important proponent of memory and cognitive function. However, sleep disturbances that often occur in dementia can increase caregiver distress. And so all of this is to talk about, in that Lancet article that talks about up to 45% of dementia risk factors are modifiable lifestyle factors. It really makes them a target for intervention, behavioral interventions to slow cognitive decline and reduce cognitive disparities. So now I want to talk about spirituality. So spirituality is a cultural resource for resilience, especially among socially marginalized communities. It may increase positive psychological emotions. You think of things such as hope and optimism. It can help reduce stress and anxiety and provide resources such as beliefs and practices. And some spirituality may include religion, and we'll talk more about that in the next slide. But really, spirituality provides a greater sense of purpose and meaning for people in challenging life circumstances, right? It might provide a framing for understanding a certain situation if you're facing a serious illness or a loss. We know that the studies in mild cognitive impairment and the dementia populations looking at spirituality are more limited compared to other populations. So you're probably asking, what do you mean when you talk about spirituality? So I use a broad definition that was formed from a consensus conference, really designed by spiritual care experts to coin and define what spirituality is so we could really advance the science. And they have defined it as a way to seek and express meaning and purpose and experience connectedness to the moment, to self, to others, the natural world, or the significant or sacred. And it's really seeking these things to find peace, right? Spirituality is broader and more abstract, but for some people, they support their spirituality through religious activities. And that's more aligned with one's faith tradition, beliefs, and practices that might be related to an organization. This is a framework that I've often used for my research to inform relationships between variables of spirituality and religiosity, because, like I said, they can overlap. And much we see in research is spirituality and religiosity overlap in research. So sometimes you'll see them spirituality slash religiosity, or you might call them R/S. But this is the vulnerability stress model that incorporates spirituality and religiosity. And it's formed from two theories, the diathesis stress model and the transactional theory of stress and coping by Lazarus and Folkman. So basically, this horizontal model posits that health that you see here at the end is the result of an individual's reaction to stress through several factors, right? So we have predispositions, we have health resources, and we have coping behaviors. Um, so Zwingman and Klein have added some factors and facets from spirituality and religious research to this model, which kind of helps provide a little more structure to these concepts. So number one is the centrality of religion, maybe the importance of spirituality or religion in someone's life. Number two is religious and spiritual resources that they might use. Number three are spiritual needs, like the need for connectedness. Then number four are religious and spiritual coping, so ways people use spirituality to cope. And then number five is spiritual well-being. I want to talk a little bit about spiritual needs before I share some of my study outcomes. What are spiritual needs, right? We think about that. And it kind of goes back to the definition that need for a sense of meaning and purpose, right? To find peace and well-being through connectedness. And I think we saw through the pandemic the importance of connecting with others, right? That special connectedness piece. We think about social isolation and loneliness. I did a literature review on the spiritual needs. It's integrative review. You can see the QR code there. So we looked at qualitative and quantitative studies that identified spiritual needs in persons living with dementia. And I'm going to say that they ranged all over the place. The studies were from all over the world, which is interesting. But I just kind of want to talk about a few of these. Some of the perspectives of people that shared, as I said, this included qualitative studies. There were providers, there were caregivers, there were workforce at assisted living and long-term care that answered questions about what they thought were spiritual needs that they saw in persons with dementia. I think some of the things to point out here are they are essential really to support personhood, right? To really identify what's important to the person, what supports meaning and purpose for them. They can be at the individual or in community level, right? When you think about different activities, they can be individualized or they can be in a community with other people. Um, I think that these are important to think about and sometimes people, as they progress through dementia, they may not be able to connect with those activities. But a lot of the people and studies that we looked at said that they sometimes just need persons with dementia just need help connecting, right, with those resources or those spiritual rituals that they've done their whole lives. So I felt like that was really interesting. So just I'm going to go briefly over these 5 projects. And I'm not going to go super into detail about methods for the sake of time, but I just want to kind of share some of these. So first, I'll talk about some qualitative findings from a study that we did. And then number 2, I want to look at associations that we've looked at about spiritual and religious practices with some health outcomes. And then number 3, starting to explore potential mechanisms, like what are those mechanisms of spirituality that might affect cognitive health? Number 4, what exactly are the cognitive domains that spirituality might have an association with? And then number five, what about changes in religious and spiritual activity? How could that affect cognitive health? So the first study that I'm going to share, this is a qualitative study that was conducted in Central Texas with 11 dementia caregivers. The sample was primarily white and female. We explored religious and spiritual practices for coping with stress from the perspective of dementia caregivers. And so we asked about them and we asked about their loved ones living with dementia, like what these practices were that they were using for coping and how they helped them. This was a descriptive qualitative study, and this was during COVID. You can see the time frame there with telephone interviews. So this is just kind of a summary of the religious and spiritual practices that we were able to identify from the data from this qualitative study. Caregivers reported using meditation, yoga, prayer, religious services, worship, and Holy Communion. And then they reported for their loved ones with dementia that they were using prayer, religious services when possible. Sometimes that included the television because a bunch of in-person were closed down, worship and music, using sacred objects, which I felt was really interesting, especially as persons with dementia progress. The caregivers were talking about they would see religious objects about the house that would be moved around, that persons were engaging with them. They answered how practices helped them. Caregivers reported it really helped calm them. It prompted mindfulness. It helped them get to sleep at night, which I felt like was really interesting. It provided a sense of security. Again, like thinking about that meaning making, it provided a framing for them to try to understand the situation that they found themselves in, right? Like you're thinking about during COVID, social isolation, there was a lot of unknowns for caregivers, right? Caring for people living with dementia during that time. They reported that older adults with dementia, when they would engage with these practices, they noticed that they had decreased anxiety or it improved their mood if they were anxious. It provided a calming effect and it really prompted memories, which I felt like was interesting. So the second project, these are just some cross-sectional studies that I conducted using secondary data in respondents with mild cognitive impairment and dementia using two publicly available data sets. So we looked at, we used the HRS, the Health and Retirement Study, and then the Aging and Demographics and Memory Study. So HRS, if you're not familiar with it, it has older adults responding in the US aged 50 years and older. It's conducted every 2 years, started in 1992, and it's sponsored by the NIA and the Social Security Administration. And then the ADAMS is actually a sub-study of the HRS. So it's a smaller group, right? So I believe at baseline it was about 1,700 individuals, and they were ages 70 years and older. And it really was the first in-home assessment study across a national sample. So I don't want to dwell too much on sample descriptives here, but I do want to share our findings from the importance of religion and spirituality and religious and spiritual practice frequencies that you can see in the circle here with the gray circle. So these were smaller sample sizes, and I'll get to that information in the next slide. But for persons with dementia and mild cognitive impairment, we found that 59 to 100% reported religion and spirituality to be very important. A higher importance was found among Black and Hispanic participants. Religious attendance frequency, at least once a week or more, was found highest in Hispanic and other participants. And then frequency of private prayer, at least once a week or more, was highest among Black and Hispanic participants. Now, these items were asked in the HRS as self-report. So as you see, we have a small sample size here because we only included persons and some of the samples with dementia and then one of the samples with mild cognitive impairment. But we basically looked at religious and spiritual facets. We had religious service attendance and we had private prayer. And we looked at associations with neuropsychiatric symptoms, cognitive function, and sleep disturbances. So we were able to control for social interaction, for religious service attendance, because that's one thing that that we believe is a mechanism of religious service attendance, right? Is that social interaction piece. So we did find significant associations. Again, these are small sample sizes and cross-sectional, but it's interesting. So higher frequency of religious service attendance and higher frequency of private prayer were each associated with better cognitive function, fewer neuropsychiatric symptoms, and then fewer sleep disturbances in persons with dementia. We found the same results in the mild cognitive impairment sample looking at religious service attendance. There was an interesting finding for the sleep disturbance. You see that the sign changes. T1 is for time point 1, T2 is time point 2. We looked at, again, cross-sectionally, these associations here and then 18 months later here. And you notice for sleep disturbance that at the beginning, it was associated with higher sleep disturbance, and then later on, it was associated with fewer sleep disturbances. So I'll talk a little bit more about that coming up. Number 3, kind of thinking about what could possibly be mechanisms for spirituality, that association with cognitive health. This is a hypothesized model of potential mechanisms structured across psychosocial, behavioral, and neurobiological variables for the association. So I'm currently finishing up this systematic review, and I'm going to share some findings of studies that we've done. But I think it's interesting to think about the components, and I think it's more than one, right? You think about healthy behaviors, you think about stress reduction. So there's lots of things to think about here. This is another, some more secondary data analyses that we did using the HRS data set. In this last one, you see here, this last row, the first 2 rows were separate studies that we used the MIDAS data set, which is the midlife in the United States data set. And we explored relationships between religious and spiritual activities with sleep as a potential mechanism and with systemic inflammation as a potential mechanism. Now, these are just association studies. We did not use mediation for this, so that's something that needs to be done in the future, but just talking about exploring these possibilities now. We examine religious service attendance and daily spiritual experiences with sleep quality. And for daily spiritual experiences, you're probably asking, what does that mean? And so that was a 5-item scale that was used in MIDAS. And it basically asked participants to self-report. Again, I feel deep inner peace. They either agree, disagree, highly disagree with that, things like that. So I have a strong connectedness to all of life. Those are a couple of the questions for the 5 items. So we looked at sleep quality that we measured with the Pittsburgh Sleep Quality Index, which I believe has 19 items, and we're able to control for various social and health factors because we had larger sample size for this. So the sample size was around 1,200 for participants looking at the religious service attendance associations, and around 1,800 for the daily spiritual experience associations. And we found that higher religious service attendance and the daily spiritual experiences were associated with better sleep quality in each analysis. So the MIDAS looks at adults aged probably around 25 years to 90. And then the HRS, which I'm going to talk about next, that's older, right? So that's 50 years and older. So for the HRS study, we looked at religious service attendance and then spirituality individually, each of those facets individually. And we looked at those associations with a biomarker of systemic inflammation, C-reactive protein. And we looked at older adults, like I mentioned, it starts with age 50, but goes up over 3 time points of 8 years using this HRS data. Now, spirituality was measured this time with the brief multidimensional measure of spirituality, which is a 4-item scale, again, self-report. And it basically measures a person's beliefs and practices regarding spirituality. Items that it includes would be like if you agree or disagree with something such as, I believe in a God who watches over me, the events of my life unfold according to a greater plan. I try hard to carry my spiritual beliefs over into all of my dealings in life, things like that. And we found that for both higher religious attendance and spirituality, these were associated with lower C-reactive protein over time. And considering why this may be the case, we've discussed the possibility. You think about the psychoneuroimmunology theory that suggests psychological stress may trigger the release of cytokines, which are chemical messengers that can cause inflammation and lead to an increase in CRP levels. So you think about chronic stress, depression, anxiety may prompt a pro-inflammatory immune pathway. But when you think about religion and spirituality practices, we talked about how they can prompt positive psychological emotions. And we know that optimism is associated with lower systemic inflammation. So it's possible that these practices prompt optimism, maybe a greater sense of happiness and life satisfaction and well-being that may have an effect on the stress of the body, lowers the stress and possibly inflammatory markers. Again, used for coping mechanisms for stress. So that's interesting to think about. For this fourth project, cognitive domain. So we were thinking, okay, we found these cross-sectional associations with cognitive health, and we mainly have looked at the CDR, which is the clinical dementia rating. In the HRS, they use the TICS. It's like a telephone cognitive scale for the HRS. And so we think about are there specific cognitive domains that religious and spiritual practices may be associated with? And so for this next project, we wanted to see, which domain may be associated with these practices, kind of get a little bit more information. So for this study, we had data that was from the University of Pennsylvania Alzheimer's Disease Research Center and a social determinants of health survey of older Black and white adults aged 55 years and older that were living in the greater Philadelphia metropolitan area. So what we did is we looked at an item of spirituality and an item of religiousness with cognitive domain. So we looked at memory and executive function, and you can see here the different measures of memory and executive function that we were looking at. We had about 158 in the sample. We controlled for potential confounders of age, education, sex, and social interaction, and we explored interactions with race, ethnicity. So the sample was around age 55 to 97 years, higher education of 16.7 years. We had about 28% were Black adults, and the sample was primarily female at around 65%. So we found significant associations with spirituality with memory, and that was measured with the Benson delayed recall test, but we didn't find associations with executive function, and we did not find associations with religiousness. We did not find a significant interaction with race, ethnicity, which I was surprised to find. It's possible that our sample size was too small. The number of Black older adults in the sample were about 44. So I don't know if that had influence on our findings or not. But thinking about why spirituality might be associated with a cognitive domain of memory, was really thinking about its potential through a link of emotion, right? So spirituality supports awareness and prompts those positive psychological emotions like we talked about, which in turn link to memory, as emotional memory is strong and less likely to be forgotten over time. So I think that's a possibility. So again, we only looked at those two cognitive domains in this sample that was primarily in the Philadelphia area. So future studies really need to look at a larger sample size across the US that's more representative, and look at various cognitive domains, looking at orientation, thinking about attention, things like that. Again, self-report, that is the main way that we measure these religious and spiritual variables, which are, have a limitation of bias, right? So we need longitudinal studies, and I'd be interested to see There have been other studies out there looking at, interactions across race, ethnicity, and there are some studies that have found some findings there, but I feel like nothing has been consistently reported over time. So again, more studies are needed. So this last project I'll share, before I kind of summarize all of these together, looking to see, if spiritual and religious practices may support cognitive health, like if they change, right? So it's unclear if changes in these practices are related to cognitive decline. So for this study, we looked at associations here and we used a framework from the NIH Health Disparities Research to really inform our approach as religious and spiritual factors are sociocultural and behavioral, right? We talked about coping factors for stress. So we used the same data that I just mentioned, that University of Pennsylvania ADRC data with the Social Determinants of Health survey. So it was Black and white older adults in the greater Philadelphia metropolitan area. The sample size was 158, and these were cognitively normal older Black and white adults at baseline, right, when they were enrolled. Um, and we looked at an item. They answered a question, again, self-report. See, the following event happened to you during the previous year. You had a major change in church activity, which could be a lot more or a lot less than usual. And then for cognition, we had the CDR score. And we were able to control for age, education, sex. And again, that social interaction, the number of friends interacted with monthly was how we measured that. And so what we found significant associations between that major change in church activity over the last year with lower cognition, controlling for the covariates. And we found it in Black older adults. Again, you remember the sample size for Black adults was just 44, so it's fairly small as well. But we did not find associations in white older adults, which is interesting. So thinking about, what this might mean, again, cross-sectional, so it's limited. We had self-report, small sample size. Is it possible that that maintaining church activity is important in supporting cognitive health? We think about socialization opportunities with church activity, right? With that religious service attendance, maybe it provides resources and supports that church goers and church administration provide for, followers that come. It's possible that as some individuals progress in their cognitive decline, that major change in church activity among Black adults may serve as an early indicator of cognitive change. But again, this is limited study, and more studies are needed to kind of look at this a little bit further. When you think about the studies that have been published on religious service attendance or church activity, usually for older adults, you'll see that if they have a major change in church activity, it's usually going less because of functional problems that have developed or illness. So just to kind of summarize the 5 different projects I've shared with you today, I know it's a lot of information, so I thought this might kind of help sum it up. But religious and spiritual practices that persons with dementia and caregivers reported were prayer, meditation, religious attendance, and music or worship. They reported that it decreased anxiety and calmed them and improved their mood, prompted cognitive stimulation and memories. We found that religious and spiritual practices are associated with better cognitive scores, fewer neuropsychiatric symptoms, and mild cognitive impairment and dementia, and then the fewer sleep disturbances in dementia. And as I mentioned earlier, at that time point two for the mild cognitive impairment sample, we saw that at time point two, as the frequency of religious service attendance decreased from time point one, sleep disturbances increased in mild cognitive impairment, which is interesting. We found a higher frequency of religious and spiritual practices in historically underrepresented participants. We started exploring potential mechanisms of better sleep and lower systemic inflammation. We found that spirituality was associated with better memory in our small sample size in Philadelphia. And we found that major change in church activity was associated with poor cognitive scores in Black older adults. So again, I feel like I'm sharing my studies with you. There are other studies out there that have looked at longitudinal associations, have started to look. Lisa Barnes is a co-author on one that came out last month that's exciting using HRS over time. They found that religious service attendance was associated with a slower decline in cognition in Hispanic older adults. So there are more studies that are needed to look at larger sample size that are diverse, right? Because we know that historically underrepresented groups find spirituality and religion important and may use it for coping, and they are at greater risk, right, of cognitive disparities and dementia. So looking to use groups and work with groups to look to see if these practices could slow cognitive decline over time, and could provide stress reduction activities for people with mild cognitive impairment and dementia. So we kind of think back to the spiritual needs that I talked about in the beginning. And the importance of really connecting persons with memory problems, right? So, cognitive impairment and dementia, connecting them with those meaningful resources, right? Whether it's rituals, religious rituals, spiritual activities, connecting them with those resources for coping is really important as a source of personhood, right? Supporting that personhood. So, really identifying in the mild stage what those sources might be, what are those practices, so that we can help support people as they progress. And it's possible maybe that these practices might slow cognitive decline. But again, more studies are needed. We need studies over time with larger sample sizes. And we need to test mechanisms. I feel like the mechanisms are like the hot topic right now, but using mediation analysis, we need to look over time to see what are these factors. Um, I think there are going to be, various ones. And then looking to see in a larger sample size, variations across race, ethnicity, and gender. Because I feel like there's not a one size fits all. There's a lot of different facets and things to consider. But I'm excited about where this is going. Yeah, so I'll just stop there. Again, I just want to acknowledge my funding for this work. Jonas Mental Health through the Jonas Philanthropies, University of Pennsylvania Population Aging Research Center, and then my T32 support from the National Institutes on Nursing Research. These are just some of my mentors and collaborators on the works that I've shared with you today. I also want to mention other collaborators: Cassis Boting, Hyung Oh, Ruby Luke Wawa, Joshua Sibu, Benjamin Doolittle, Hui Zhao, and Fran Ezekiel Conquo. Thank you for allowing me to talk about my topic and bearing with me as I talk about all the different facets of religious and spiritual practices. We have a lot more work to do to continue to try to understand these facets as social determinants of health, especially, and how they might influence cognitive health. Please reach out to me if you have any questions. Always happy to answer those to collaborate. So thank you. I'll stop sharing now. Okay.
Thank you so much, Kat. I thought that was fascinating. This is not the first time I heard your talk, but each time I'm learning something new. So I want to open up to the audience and see if there are any questions, comments.
Hi, Kat. So wonderful of a presentation. And I'm just going to ask this out loud because it's a little faster for me than typing it in.
Sure.
And thank you for sharing really from the beginning your personal story and how you got into this. And I'm sorry for the loss of your parents. I'm interested in understanding because we talked a little bit about before we got online here about maybe what we know about clinicians' comfort in addressing spirituality, Because I just think about all the different backgrounds that clinicians may be coming from, but yet they may be asked to engage in some of these types of activities with patients. And what do we know about that? And it's related to that also as a role of chaplains, chaplaincy.
Yes.
Where do they fit in this picture?
Yeah, no, that's a great question. There's been some work. Tracy Balboni published a literature review in JAMA this past year with other religious and spiritual experts. She is a physician at Harvard, and they talked about, what are the different health outcomes with religious and spiritual facets, right? And it's talked about in research more and more, and patients bring it up, but it's still not fully addressed, in the clinic. I would say that um, like I mentioned earlier, people facing end of life or loss or serious illness, it may bring these components more into play and more into focus. But in my research and kind of what I've seen out there is that a lot of people, they either feel comfortable talking about it, clinicians, or they don't. They're not really sure whose role it is to talk about. They don't know, they may not feel comfortable talking about it, where others do. So I think there needs to be a lot more education on, okay, if someone brings this up, how can we address it? Do I feel comfortable as a clinician talking about this, or can I refer them, like you mentioned, to the chaplain? So chaplains, there's a developing chaplain network that's called Transforming Chaplaincy, and they are really getting into research, which is really exciting. And they're trying to do more research on spiritual care and support in as clinicians and in hospitals and in clinics. So that's going to be an important movement, I think, to see how they might address patient um, issues. But there's a lot to consider, especially as social determinants of health. Their religion or spiritual beliefs might influence people's decision making, right? Whether they want to, um, agree and participate in genetic testing or vaccinations or whatever you want to call it. Like there's people have strong beliefs about what they believe, right? That might revolve around religion or spirituality, and kind of knowing where the patient is coming from can really help us as clinicians to give them, scientifically supported information and educate them on choices. And I think there's a lot of work that needs to be done there, but it is a great question, and it's not always addressed um, with patients.
Thanks, Kat. And actually, this reminds me of a little bit just my Thanksgiving weekend, where I'll just mention that I noticed that my mother-in-law has been brought up in a certain religious background, and her mother is still alive, and she basically is kind of losing her hearing and eyesight, and but she has a very strong religious background. It makes me kind of think about the maybe congruence of concordance of the caregiver and the patient and their
Yeah.
religious beliefs, especially
Yeah.
interfamily.
Yes, no, I think like looking at network and dyadic influences, it would be really interesting. There's been one small study, and I believe Coin in Italy a few years ago did a study looking at caregiver religious and spiritual facets with a person with dementia's facets. So a little bit of work has been done there, which is interesting. But I think more work would could really kind of enlighten like what that looks like and what's helpful, what's not. I don't know. It's kind of fascinating.
I think actually about how many families probably struggle with that, especially with like informal caregivers, just
Yeah.
being family members oftentimes, and that
Yeah.
religion within the family can be such a
Yeah.
big topic.
Yeah, for sure. And one of my colleagues at Iowa has done a study looking at data using machine learning to look at clinician notes, right? So those unstructured notes in the hospital system in Iowa, looking to see if spiritual care or existential, care is really addressed or documented in clinician notes, and it's very minimal, especially for persons with dementia. So I think that's something to kind of look at like could we try to, work with caregivers to identify those sources or resources that bring that person comfort, right? That have meaning to that person to help them as they progress. I don't know. I think it's something that we could do a better job at.
That was a really interesting discussion. My father-in-law is actually a hospice chaplain, and we've informally talked about this, how the spiritual beliefs or religious beliefs of a person who is on hospice and how the families, what they believe when there's an incongruence, sometimes that poses challenge.
Yeah.
But I'm really excited to hear about the chaplain group that you mentioned, because
Yeah.
informally my father-in-law and I have talked about this, and
Good.
there's a need. I don't see any questions on the chat or the Q&A function, but I do have two questions. So while we wait for others questions pop up, my first question is that the spirituality or religiosity are tend to be associated with community of the people who share the same beliefs. So I'm curious,
Mhm.
in your work, because there are increasing focus on like the role of community support, the community engagement, and things
Mhm.
like that. Do you think that perhaps this role of spirituality in a person's well-being may be like equivalent, not quite the same? It's not like equal sign, like A is B, but
Yeah.
do you like for people who may not have like
For sure.
particular strong spiritual
Mhm.
beliefs or something, like would this kind of be same theoretical
Mhm.
mechanism or the role of having a strong community engagement?
So you mean like for people that are not religious, but
Yeah, like can
maybe are not
we?
spiritual? Yeah, I mean, I think there's a real community component to it, right? That social support, that social interaction for connectedness. Um, and really thinking about that definition of spirituality, connecting with the moment, with self, with nature. Like some people connect with nature and not other people, right? So I think it's really about finding what those components are for the individual. I think it's very individualized. Um, and it's not a one size fits all, right? So you have things that are meaningful for you, and I have things that might be meaningful for me. And how can we figure out what those are and help support you in those and to continue to engage in that activity, basically. Um, but, as we look at the landscape, it's changing. So, we've had older adults tend to be more religious than younger adults. But we're starting to see that shift and that younger adults are identifying more as being spiritual and not religious. And older
Mm.
adults are more identified as being more religious and not necessarily, they might say, I'm not as spiritual, but I'm more religious. So it's interesting to see that landscape changing,
Mm.
especially after COVID, which I think kind of helped shake everything up and made people look at things differently and reflect on the importance of things in life, and the importance of connectedness.
That actually leads to my second question, was you mentioned about the mechanism or like
Yeah.
unpacking, like, how this is all playing out,
Mhm.
and the connectedness is one, but the other
Yeah.
thing that I was thinking, perhaps you did look into it and maybe I missed it in your presentation, but like sense of purpose or meaning of
Yeah.
life, like
Yeah.
that is strongly associated with the degree of spirituality or religiosity. So
Yeah.
have you
Yeah.
looked at that as well?
Like I mentioned, I'm doing the literature review now, but the next proposal that I'm doing is looking at those mechanisms, right? To use mediation analysis over time to see what those are. I did actually get an article in my inbox. I don't know if you do like the Google Scholar,
Yeah.
I'll like email you. So there's a professor at Duke that just published an I think it's Aging and Mental Health journal, and it was just cross-sectional associations using HRS, but they found that positive negative affect partially mediated the relationship between religious activities and cognition. So I think that kind of goes along with that, positive
Mm,
psychological emotions, which go into life purpose. And so, yeah, I think that's definitely a proponent.
cool.
Yeah.
Kat, this was such a wonderful and informative presentation. It's such compelling evidence about the importance of really thinking about spirituality and religiosity as part of like care for people as they get older, not only for people with dementia, although certainly there seems to be some real benefits there also. So it's so important that this kind of information gets put out there so that especially folks here in the network as they think about the workforce and their what their competencies are that they need. I certainly see this need to incorporate discussions about religion and spirituality and as you mentioned, understanding this comfortability, understanding whose role this is. So many
Right.
questions come up.
Yeah, for sure. Yeah, there's a lot to be done.
Well, thank you so much for sharing all this wonderful work that you're doing. And again, this is recorded, so hopefully we'll be able to share it out with many others and let them know about this great work. But thank you so much for taking the time. And Jen, thank you so much for moderating today's discussion and inviting Kat today.
Thank you. Thank you all so much for having me.
Thank you. And have a great day, everybody.